So as Steve mentioned, we're going to be sharing with you some insights about enhancing access to patient-centered primary care in Ontario. So the project that I'm going to speak to you about over the next 20 minutes or so is about a citizen panel that we convened at the Health Forum in fall of 2016. And that citizen panel was part of a larger project around thinking through an evaluation plan for health links. So the idea was to try and get some information to feedback about the development of health links in Ontario, which for those of you who don't know what health links is, it's a model of care in Ontario designed to help coordinate care for those with the most complex health conditions in the province. So I'll jump into the next slide. So just in terms of acknowledgements to start off with, the funding for the brief and the panel that we convened came from the Ontario Spore Support Unit, which is supported by the CIHR and Government of Ontario, and just my co-authors, Kerry Waddell and John Lavis, for the citizen brief. And so what I want to do first, is, before we get to the top 10 insights, is to give you a bit of context about the project itself. And the idea here is just to give you kind of a snapshot about some of the key aspects of the project and then the insights. The much more detailed information is written up in our reports that are available on the McMaster Health Forum website at mcmasterhealthforum.org, where you can read both the citizen brief that we sent to the panelists before they came to the panel and the thematic analysis of the deliberations that we had with citizens during the day. So in general, why is this a priority? So primary care is one of those things that is front and center on the government's agenda at the moment, at least in Ontario and also in many other provinces. As many of you probably know, there's convincing evidence that strong primary care is associated with lower costs as well as improved quality of care. And it's really a foundation of the health system. So it's central to achieving high quality clinical care, improved patient experience. It's the first access point for most into the health system, and then into referrals to other sorts of specialist care. And in Ontario, it's a core component of the, I should have taken out proposed, but as now of the legislation, it's called the Patients First Act, in particular around the planning of primary care that's going to be happening within the LHINs and specifically at the community level through sub-regions within each of those LHINs. So necessarily when we're talking about primary care and making it patient-centered, it's not just about primary care, but as Gillian will talk to you about, it's about coordination not only between sectors, but also between different types of providers, so making sure that primary care is linking with specialty care and also coordinating with home and community care and long-term care and other sectors as well. So let's move on. So now that we've heard about primary care, what is a citizen panel? So at the McMaster Health Forum, we've been running a citizen panels program now for a few years. And the idea is that we give the opportunity for roughly 14 to 16 citizens in each panel to make informed judgments about how to address high priority health related issues. Each panel that we convene is informed by what we call a plain language citizen brief that emphasizes the use of, or that uses research evidence and local data and evidence to describe the health issue or the problem that needs to be addressed. Usually 3 options or elements of an approach to address the problem and implementation considerations. And that we do our best to try and write all of that in plain language and in a way that's engaging for citizens to read. And that's sent to our citizen panel participants roughly 2 weeks before they come to the panel. And within that brief, there's a number of questions embedded in each of the sections that help to get them thinking through what we're going to discuss during the day. So the idea is that they're coming prepared and informed for a deliberation. And so the deliberations themselves are facilitated, so I facilitated this panel, and the aim is to try and uncover unique understandings about health system issue and try and spark insights about viable solutions that are aligned with their values and preferences. So it's really about trying to engage citizens in identifying their values and preferences for how do we tackle complex health system issues. And then we use from the deliberations, we use that information to develop a thematic summary of what came out during the day. trying to pay attention where there's relative consensus on different areas, as well as where there's divergence among people in the group. And as you'll see later when I talk to you about who is in the panel, so for recruiting citizens for all of our panels, we aim to make sure we've got a diverse group of people in the room. So diverse in the sense of age, gender, ethnocultural background, socioeconomic status, as well as lived experience with the issue. So for this one, we aim to make sure that we had people who came from different models of primary care, whether it was in a team-based model of family health teams, whether it was with a solo practice primary care practitioner, and those without a primary care provider, as well as those living with multiple chronic health conditions versus none. So I'll just move on to the next slide. So I'll just run you through the highlights of what we presented to the panel participants. So you get a sense of what they saw before they came to the panel. And then the insights, 10 insights I'll give you are from the panel itself, from what the citizens told us after they read this and then came and deliberated with each other. So when we framed the problem, we identified it according to these bullet points. And these were just the high-level headings we provided in the brief, and then we gave them some illustrative examples underneath these. So them being that primary care is not always providing access to services that address what make us sick. So the idea that primary care isn't necessarily always focused on health-promoting activities, but rather more reactive to addressing health concerns after they've emerged. The number of people living with one or more chronic diseases continues to grow, which places strain on primary care, which is the point of first access for most people. Ontarians having unequal access to primary care and many lacking timely access. So the idea that some in rural and remote regions often have difficulty getting access to primary care, and those even where it's well served, it's hard to get access when they need it. The patient not always being put at the center of care, so that's the notion of kind of both continuity and coordination, and engaging people in their care and make sure that it's focused on their needs. And relatedly, difficulty in connecting people to what they need due to a lack of coordination between the systems. So here, not just talking about primary care, but many other parts of the system. We also pointed out to them that many past reforms have tried with some success to address the challenges. So most notably, the move to team-based care of family health teams, but as we know, that serves a certain segment of the population. There's only serving roughly 25% of the population in Ontario. And other system features make it difficult to provide patient-centered primary care. So things like remuneration models not being supportive of many of the, addressing many of the issues that we flagged in the brief. So that was the issue. Again, those are broad strokes for the issue that we put in front of them, and we presented these verbally to them during the day and asked them to react to them. In terms of the policy elements that we put in front of them, we always put 3. So for this one, it was focused on ensuring all Ontarians receive the care they need when they need it. So we identified that some approaches included within this could be more flexible appointment scheduling, enhancing team-based approaches with most responsible care provider embedded within it, and whether that could be a nurse practitioner, using broader array of mechanisms for interaction. So perhaps thinking through, could we use smartphone apps or secure telephone and email consultations, and making sure that care is culturally and linguistically appropriate. Again, these are ideas that we put in front of them, and then in the brief we provided a very high-level summary of some key findings from systematic reviews about these options. And then putting the patient at the center of care. So the things we highlighted here that could be part of this were personalized care plans, helping folks do a better job of managing their own care when needed, also engaging in shared decision-making between providers, patients and their caregivers and family members, using personal health records for engaging patients to manage their care. So that's often talked a lot about now, being able to, how do we provide access to citizens to their own health records, using care coordinators for those who are the sickest, and making sure that there's communication between the care providers. And then lastly was around accountability. So identifying what we can measure to say whether the primary care system is performing according to patient and citizen expectations, evaluating, making sure there's a robust evaluation plan in place, and then public reporting of performance. So the idea is that we're getting their reactions to these and trying to hear what they valued and what they thought the direction the system should take. So very quickly, I'll just give you a sense of the specific questions we posed, and I'll go into the top 10 insights. So the broad questions were related to just asking them what has made primary care work well for you, your family, or your caregivers, what should it look like in your community, and what should it look like for different groups. So for people who are healthy, those with some ongoing care needs, those who are the sickest, and those who are often marginalized or lack access to needed care. Specifically to element 1, we asked them if they had a preference for whether a family physician or another type of primary care provider is most responsible for their care over time, how they think technology could be used, what do they expect in terms of receiving timely access. So does it need to be same or next day, or is it more nuanced than that? And if your most responsible care provider is not available, what would they prefer? Would they prefer to wait until they could see them, interact with them using technology, or interact with another provider that they may not know? And if they had adequate access to care, do they think that walk-in clinics are needed, and why? For number 2, we asked them what would be helpful to support you to take ownership of your health, and what do you want and expect from primary care to make sure that it's seamlessly coordinated. And would they be comfortable with receiving care from teams of providers with expertise in common conditions, so things like low back pain, depression, end-of-life care, who can collaborate. And what do you expect and want in terms of the use of technology for providers using their health records and for those having to access their own health information. And then lastly, for number 3, we asked them what would be meaningful for them to know about how the primary care system is performing. Do they think it should be publicly reported? And if it were, at what level? And should the wait times between referral from primary care to seeing a specialist be reported? So that was the glimpse into the brief. So I'll go into the insights as well as give you a sense of who was actually at the panel. So we had 13 participants, 7 men, 6 women. Then we recruited them from the Asking Canadians panel. And so we give them our criteria for how we want to recruit, and they go out and make sure we get a random sample according to the criteria that we sent them. So here we had a mix of people from different regions in the province, mixes of ages, urban, suburban, and rural. 5 people living with multiple chronic health conditions, 4 living with mental health and addictions, and a good spread across different income categories, as well as being ethnoculturally diverse. So for the 10 insights from citizens, the first one about the problem is that citizens pointed to patients having inconsistent access to primary care providers. Lots of people spoke to this issue, whether it be difficulty registering in a practice, some seeing that there's an element of unfairness about who can get a family physician. So a lot of people spoke around the table about how it seems to be based on connections, not necessarily based on need. At least that was the perception. And difficulty getting access when needed. So some people talked about that there is sometimes a need for same or next day access, but also it's more nuanced than that. And sometimes for less urgent appointments, they still face difficulties in getting an appointment within a week or 2 weeks. And then as a result, many then seek care in suboptimal settings. So a few talked about going to emergency departments or urgent care centers or walk-in clinics to get care. So the second insight's about the problem, primary care not always comprehensively addressing what people need. So whether this be complementary services like home and community care or rehabilitation, which many saw as being medically necessary, and many expressed frustration that often these might require additional out-of-pocket costs or are inconsistently covered throughout the province. Lack of available supports from other sectors, so those things that that aren't necessarily in the health system but are really critical for ensuring people stay healthy. So access to disability claims or income supports as 2 examples. And some spoke to not being able to register all of their family members with their primary care provider, that they only allowed them to do so but not others. And many lamented the inequitable access to team-based care, so wondering why there are some areas of the province that are well served by team-based practices and others not, with many valuing the idea of moving towards a team-based model and limited time with the family physician to address their needs. So many talking about the 15-minute appointment rule or only being able to address one issue when they may have many. And then second here was that technology is adopted slowly and inconsistently. This comes up in almost every citizen panel that we do. And many people speaking to the inconsistent use of interoperable and electronic health records and just wondering why we can't move towards this type of model in the system that would help with coordination. So the third about the insights of the problem, and then I'll move into the solution side of things, is that the theme was that individuals are not always accountable for their own health. There's a lot of discussion on this during this particular panel, interestingly. So one person said there's no accountability on the patient to take care of themselves, with the recognition that they can't take on some aspects of their health that might be out of their control, like the social determinants of health. The challenge in balancing expectations that people care for themselves while also respecting many of the social and structural factors, such as low socioeconomic status, and lack of supports to ensure people are knowledgeable about their behaviors. So some examples provided here were no education or engagement opportunities from primary care providers or the health system more broadly to help support awareness or empowerment. And many talked about the need for to know where to go for reliable health information, that there's such a large amount of information out there that they don't know where to go, even though they really, really want that information. So the need for that more curated, trusted, reliable source that they can go to. So insights 4 to 6. So when we talked about the overarching values in relation to the 3 elements, the 3 things across the elements came out very consistently. One is that all the participants, virtually all of them, said that collaboration is essential. If we're going to strengthen patient-centered primary care, then collaboration has to be at the center of this in terms of delivering care for patients. And also, this needs to be supported and happen through increased sharing of information, in particular related to referrals to and coordination of care with specialists. And I think Gillian would be able to talk about that. Education, so that piece coming up that they want to be empowered with information, know about their care, come into their appointments armed with information, and so they can engage in that informed discussion. And also citizens' values and preferences. So they really, across all the elements, talked about that citizens need to be engaged in the development of new models and determining what measures should be used to evaluate it. So let's run through some very quick ones about each of the elements and then turn it over to Gillian. So for element 1 specifically, this is around the access piece. So they valued timely access to a most responsible care provider whenever possible. Many talked about being very comfortable with having a nurse practitioner be their most responsible care provider. And they want to see them within a reasonable amount of time, but views on what that was varied. So some said that sometimes the metric of same or next day access, which is often what's measured these days, is important, but the measure has to be more nuanced than that, because sometimes you just don't need care within the same or next day. So it needs to be measured as what was access appropriate, and also combined with that the coordination and continuity part about that between all involved in providing care. So they talked about there's value in seeing the same provider and having access to them. Also about the need of making better use of nurse practitioners and pharmacists. But they said that many said, if not all of them said around the table, that they were willing to trade off continuity with their most responsible care provider if we were able to make better use of electronic health records and have their information and health history shared across those providers. And then lastly, the values and preferences, so and how they can contact their provider. So many really like the idea of patient portals and online scheduling and email or phone. So the idea that supporting choice and how they're able to access care. For element 2, education again came up. Also fostering trusting relationships between patients, providers, and organizations. As well as competence and expertise. So for that on the side of clinicians. So to be able to engage in providing comprehensive care and coordinated care, particularly for those with complex needs and select conditions. So that was the part about whether we can have specific teams dedicated to providing care for very highly prevalent conditions within the system. So things like low back pain and depression, or unique care like end-of-life care. And then innovation and information. So lots of talk, as I've said already, about adopting technologies. And this comes up in all of our panels that we talk about why can't we be more innovative with more patient-friendly technologies that can help with coordination and let patients be able to see their own information and help them, which would help them manage their own care. For element 3, and the 9th insight, so information, they valued information on the performance of primary care, but there was very mixed views on whether, on this, around the public reporting and the information. So some participants said that it seems like the system is always reporting on indicators that make the system look good, rather than on outcomes that are more appropriate, which was an interesting quote. And when we dug down a little further, they said that should be, if we're going to develop metrics, they need to be developed based on measures based on citizen engagement and what people value in terms of what should be measured. So that key citizen engagement piece needs to be a part of any reforms going forward. On the accountability side, so if measurements, they said if measurements are developed, they should report it on publicly and in ways that citizens can interpret and understand them. So they want to be able to see these metrics and understand them once they're made public. They also valued independence of the organizations reporting on them. So they wanted it to be a group that would be at least arm's length from the government, and they could be seen as being systematic and transparent in providing that information out there. So they identified whether it's in Ontario or a patient ombudsman that could do something like that. And then lastly, around choice. They wanted the evaluations and information and reporting to help with choice. So, and particularly around wait times for referrals to specialists to be publicly reported and easily accessible. And then lastly, and then I'll turn it over to Gillian, implementation considerations. So moving forward with the implementation of electronic health records to support coordination and the need to improve the level of citizen engagement. So those are the 10 insights. As I said, all of these are written up in more detail in the panel summary that we have on our website. So if you want to read more about it, then it's there for you. So thanks. And over to Gillian.
give them back, or their family back, their vacation days, so that they're actually not. And the primary care physician isn't having to do the coordination between this team. We do the coordination of the team ourselves. I apologize, the way this is coming across is we've got some overlap. We've done the same in our cardiac rehabilitation program. That we have a cardiologist, nurse, endocrinologist, and dietitian. We actually tried to go to one appointment for the patients to see all of them in one visit, but patients told us that was too much. So they see 2 of our team members in one visit and 2 in a second visit. And we found that we improved the engagement and the attendance by, again, minimizing the number of visits by us coordinating, but sensitive to the capacity and the energy of our patients and the ability to take in the information that they may be receiving relative to managing their post-cardiac recovery time. The other thing that we've done is we've taken the cardiac rehabilitation program and we've worked with the diabetes program, and if somebody comes into cardiac rehab, in about a year, we had about 70 people who didn't know they had diabetes when they came to us. We pool them into diabetes rather than sending them back to primary care and asking them to refer them. We pool them into the care they need, and then we integrate the care plan for that patient. And we're just in the process of pulling asthma, chronic lung disease, depression screening, and smoking cessation into that integrated care model, so patients have an integrated plan of care. And our plan is to pull the pain program and the rheumatology program all into that more integrated program, where, as we heard from the forum, people want us to coordinate specialist care that supports primary care and, most importantly, the people that we serve. So that's the journey we're on, and we're partway there. The last thing I'll talk about is the communication back in transition, and we have some improvements we can do here. Our turnaround time at the hospital is just over 6 hours, but we're dependent on the physician dictating the notes and then signing the notes before we can send them out. So as you see, we turn them around very quickly at the hospital, but we need the physicians or the nurse practitioner who's giving us the information to do it and sign it so we can get it out. So we have some improvements there. We've instituted post-discharge phone calls in some of our programs to make sure that the patient knows what they're supposed to do when they leave, and do they have a follow-up appointment with their primary care. In some of our programs, we work with primary care to make sure it's booked before they leave our organization. The electronic documentation you heard a lot about. We push all our dictated information, diagnostic results to primary care. It's a one-way push to those primary care physicians that have a health record. We don't get their information, unfortunately. The system doesn't have the capability to do that. But primary care gets all the discharge summaries, clinic visits, diagnostic information that happens in an 11-hospital integrated one patient, one record system that goes out into our primary care system. Again, trying to make sure we're building that bridge back. So the last picture really speaks to the importance of us working together. Really hand in hand is primary care and specialty care. There's lots more we can do. I'm hoping I've just shared with you a few examples of how we are trying to be responsive to the people that are served in primary care, because together we actually can earn complete confidence in the care we provide. And I'm going to stop there.
Well, thank you very much, Mike and Gillian. Well, both great presentations. I'm just going to open up another poll quickly here before we get to questions and answers. So hopefully you can give us a bit of your feedback on which of these insights resonated particularly well with you, and please also use the chat box in the bottom right-hand corner of the screen if you have any other comments or questions that you would like to ask to either Mike or Gillian. So it seems like there's a bit of a mix in terms of which comments were particularly well, I guess, well received, or most resonated. But certainly the issues around timely access and coordination, continuity of care were we're certainly up there, as were insights on citizens' values, preferences, and accountability. I see we have at least one person that's typing a question, so we'll just wait until that comes through and then address that. So while we're waiting, I just wanted to let everybody know that we are doing these webinars on a monthly basis. So you can check out our top 10 webinar page for more information on the upcoming webinars. Our next one will be March 23rd, and we hope you'll join us for that as well. So Vidhi Thakar said, thank you very much for the insightful presentation. I had a question regarding patient preferences and their e-health literacy. During your citizen panels, did patient values and preferences change based on their level of e-health literacy? Could you expand on this in either the citizen panels or any of the projects that were presented? Mike, do you want to maybe start with that, and Gillian can add in some comments?
Yeah, sure. So it's a great question. And so this did come up, and it came up really in the context of choice. So when many of the participants were talking about how it would be great to have things like patient portals or to be able to interact with providers through either video or email or so on, everyone did kind of take a step back eventually and say, but it depends on how comfortable each individual patient is with using one or more of those technologies. So many pointed to the fact that perhaps some older adults may be less willing or interested in using those types of technologies, although many are very comfortable in doing it. But the notion coming out that they want choice, so the options need to be available to be able to make that access efficient for people depending on what their preferences are. And interestingly, in some other panels that we've held, this topic has come up, and when we talk about the notion of sharing information between sites or between providers, it's interestingly usually it's been the younger people around the table in that panel who are more skeptical of doing that, given concerns around privacy of information being transmitted versus the older participants around the table. So that's one interesting finding as well. I don't know if Gillian has any insights about this as well.
Yeah, Gillian, if you have anything to add?
Yes, I think what we have found is the choice is the important part. We have some of our providers that will do email communication, particularly around things like dietitians, diabetic educators, etc., because people need sometimes help in more real time. What we have to be careful with is what's the expectation of turnaround time as far as sort of managing that. But patients do like choice. We use a lot of telepsychiatry for care, and it's very well received. We've started trying to do some remote speech language to try and better serve the population. And again, it's in the work that we've done, it's actually been well received. And so I think it is variable. I would agree with Mike that we have variable trust in people. Everybody wants their information to be available to their provider when they go see their provider, but it's distressing for people to say, well, the only way we can do that is to allow providers to have very broad access, even though they're not to access unless they need to, but they have the capability to access, and that causes more consternation.
Great, thanks, Gillian. Well, I think you certainly reiterated the point that Mike made there about choice being important in terms of something that people value in terms of accessing care, but then also some of the issues around access to information, e-health records and stuff to make that feasible. So that so it was certainly a good point. Now, if anybody else has any other questions, please let us know, or feel free to type them into the chat box, like I said, in the bottom right-hand corner. Just while we're waiting and seeing if there is any last questions, I just would like to thank both Mike and Gillian for taking part in today's webinar. It was certainly very interesting insights and comments, and we definitely appreciate your time.